You guys familiar with the acronym SWAG? Silly, wild ass guess? Well, that's what we're going to do today, and talking about where we think government health programs will go. And then I got to run out of here because I have a meeting with Jimmy John's, you know, the grilled sandwiches chain. I got a new one for him. We came up with a new sandwich for them in light of the election results. I call it the Trumpster Fire. It's white bread, bologna piled high, every type of cheese imaginable, Russian dressing, and a small pickle on the side. I'd buy that, right? Okay, Jimmy Jones, we're coming to you with the Trumpster Fire sandwich. And that'll be good in honor of last week's results. So let me just jump right in and start talking with you guys about what we're seeing here. And let me just say, as I get into it, let me remind you of the words of the great Abraham Lincoln, speaking to a nation much more divided than we are today, who said that we are not enemies but friends. And though passions may have strained, it must not break our bonds of affection. So as I try to shed a little bit of light and try to keep the barbs out of this discussion as much as possible, we'll hearken back to the words of Abraham Lincoln. So, look, the title of this session before the election result was, your biggest customer is still the regulator. And that is still true in the wake of last week's election. Government health programs still represent the biggest opportunity that all of you in this room have, and that is still the case today. If I had to give you a couple of quick takeaways from this thing, the likely election result, as I look at this, is that Medicare Advantage is probably just fine. We'll probably see some minor changes to it, like we may actually see a return to bonuses for all plans under star ratings, kind of like there was in the initial iterations of the quality demonstration. I think at this point, Medicaid is mostly okay, but there's a lot of talk about block grants, which we'll talk about in a second. Obamacare is toast. But nobody has any idea what repeal and replace looks like just yet. So we'll give you a couple of silly, wild-ass, educated guesses in a moment as to what that might look like. I think especially in states like Texas, the opportunity among dual eligibles, and especially around long-term services and support programs, are going to continue unabated and will continue to explode in this state and in others, as that is the number one or number two item in every state budget going forward. And while we can still spend funny money in Washington, states like Texas have a balanced budget law on the books, and this is the stuff that's crowding out education and roads and bridges and other infrastructure improvements. So the race to capitate dual eligibles in long-term care is going as fast as it ever has. I think we'll continue to see disruptive growth and share aggregation. I mean, certainly a Trump administration is going to mean an easier time for these big mega mergers to resume. On that point, I think Humana and Aetna will probably ultimately get approved. I think Anthem Cigna is cooked, and you can pretty much stick a fork in that, if for no other reason than if the antitrust regulators don't blow it up. Those two companies just freaking hate each other. And, the backfighting and stuff that's been going on while that deal was working its way through the approval process has just been, I've never seen anything like that in a major company merger. So I think that one's probably going to fall. But Aetna and Humana, driven almost entirely by Medicare Advantage, will likely continue. And you'll see more and more of these programs aggregating to big national companies that are capable of making the kind of investments that you need to be successful. But having said that, I think we're also looking at 40 to 50 new entrants into Medicare Advantage and Medicaid managed care nationally in this next 2 years. And they are almost all going to be big provider systems moving up the food chain and becoming their own insurance companies. Because in this age, as we'll talk about, of never been greater accountability for results, especially clinical results. Those companies that own the means of production and that blur the lines between insurer and provider are going to be the ones that are going to be the most successful. Star ratings and risk adjustment will continue to drive the market. There's never been more true than today. It's now metastasizing into Medicaid in the form of the Quality Reporting System, or QRS, that's coming online in 2019. It was already underway in Obamacare until the mushroom cloud hit last Tuesday. And so against that backdrop, this really is very much both a Darwinian and an Edisonian moment. It's Darwinian in that you don't have to be the biggest or even the smartest to be successful in this environment. You have to be the most adaptable, okay? And the companies among us that have the boldest and least risk-averse governance, and who can set bold strategies and then put the money behind them to ensure that those plans are realized, are going to be the ones that are successful here. You look at the track record of a Centene or a Molina and the new markets of the exchanges, where they have done just beautiful work by morphing and adapting their Medicaid networks and their care management approaches, especially when it came to behavioral health, into an offering that would appeal to people who have been traditionally uninsured, was a winning formula. And those were very adaptable companies that really rose to the challenge. The flip side is big national companies that jumped into the exchanges but came at it from the standpoint of large group insurance coverage and brought their commercial priced networks to the dance, were the ones that failed and pulled out, and it was like grand opening, grand closing for companies like United and Aetna. So again, to the point of being adaptable and this being a Darwinian moment. Edison was the one who said that vision without execution is hallucination. And when you're in an era of star ratings and risk adjustment and great scrutiny on execution in government programs, that's never been more true than it is today. So the whole world shook last week. We now have President-elect Trump, who's now trying to get his arms around what this job will entail. He apparently had his sit down with Obama last week and came out of that shocked out of his mind that the president actually has to work weekends. His plan was to go home to Trump Tower in New York City on the weekends, and I think Obama had to disabuse him of that notion in that meeting. And I think he's really starting to get a wake-up call for how hard this job is really going to be. But he didn't really have a healthcare platform that he laid out during the campaign aside from repeal and replace Obamacare. There were some other things that he mentioned, like making insurance tax deductible, which is kind of right out of Paul Ryan's platform. The sale of insurance across state lines, which has been an old Republican trope for 30 years. We tried this in 3 states, and not only did it fail miserably, but it failed because insurers didn't want to participate. I mean, there's a reason, because insurance regulations vary from state to state to state, and it didn't make a lot of sense for those payers to participate, so I'm not quite sure how much that's going to get us. Expansion of health savings accounts, which is great for highly educated working people, but HSAs tend to fail miserably when you try to apply them to underserved individuals and folks with low health literacy, because they're enormously complicated in trying to figure out how to spend a fixed amount of money on buying health services where there's actually precious little information available that regular consumers can understand and make smart decisions with. So there's some concern there about what that would actually mean. Price transparency, I mean, everybody's kind of talked about that, especially when it came to the pricing of drugs. And I think what we find is that in healthcare, price transparency doesn't work any more than slut shaming works, or it works, or calling somebody a racist. It just makes them put up their defenses, and you don't change any behavior, and it doesn't work the way that you think it will. So I'm not quite sure what that will get us there. Allowing importation of drugs has all kinds of problems with it. Not to mention the fact that the leading countries that manufacture generic drugs and alternatives to some of the brand names that are out there are made in countries like Pakistan and Iran. And now we've got to worry about re-importing this stuff from countries that hate us. Now we've got a serious drug safety problem that hasn't even been considered, and we're going to lay that on an FDA that is totally underfunded and about to be really deregulated potentially under this administration. And then block granting Medicaid. Now, Mike Pence doubled down on that yesterday at the Republican governors. And let me make sure you guys understand what a block grant really means, because I understand there was some discussion here yesterday that was quite favorable to the idea of a block grant. And let me just say, this is the stuff that only rubes fall for. Okay, a block grant is a fixed amount of money that would be given to a state to run its Medicaid program. So they're duping you into thinking this is going to be a lot more state flexibility, which states already have a tremendous amount of. I mean, even the Obama administration granted unbelievable flexibility to states in waiver programs for Medicaid. So, but under the guise of flexibility, the state of Texas would be taking a fixed amount of money that effectively is allowing the federal government to shift the risk for Medicaid into the state, and then that's all you get. So if you had a bad flu season, or if suddenly there was an explosion in long-term care costs in the state of Texas and you ran out of money in third quarter, you are, as my teenagers like to say, SOL, and you all can imagine what that means. The other thing about a block grant, and it's kind of inside baseball, but it's very important, the Medicaid match that Texas gets today, that's an entitlement. That comes to you at the percentage that you get in Texas, no matter what has transpired during the course of the year, okay? And it just shows up in the state's coffers, and that's the end of the story. A block grant, guys, is an appropriation. And a block grant would have to be approved through the labor HHS subcommittees of the appropriations committees in the Congress. And I don't know if you've been paying attention to what's been going on in approps in the last 8 years, but I mean, you know, even under largely Republican control, we haven't been able to get appropriations bills passed in years, really. That basically we've been living on continuing resolutions year after year to just basically keep the government open. So you're just for the sake of flexibility in this program, which you already have, you're now going to take on an enormous amount of insurance risk on the sickest, most vulnerable patients in all of Texas, and then subject yourself to dysfunction central, that's what we call DC now, appropriations on an annual basis, and wondering whether or not that money's actually going to materialize. So I would encourage you guys to really kind of see these things for what they are and not get hoodwinked into taking a block grant in the state of Texas, because it is one of the biggest, if not the biggest line item in the state budget. And if that block grant isn't enough to keep the lights on some year in the future, then the University of Texas funding goes right down the toilet, and then God knows every other state priority that you might see. So, you know, buyer beware here as it comes to some of this. Now, having said that, anybody who tells you they know what's going to happen, as I said in Politico last week, is smoking something that's excluded from Medicare Part D coverage. And which several states made legal last week, and a rare bit of good news for liberals. So there's two paths to the cornerstone of the Trump agenda, which was repeal and replace. Now, Trump just said last week that he was going to call a special session on Inauguration Day to do repeal and replace. Okay, which is just absolute crazy talk, because the Republicans have spent the last 7 years trying to come to consensus on what replace would look like, and they still haven't been able to come up with it. Now they're going to come up with it by January 20th. No, I mean, I think, yeah, these guys are getting something not excluded from Part D, in Part D coverage either. There's two different ways they could do this. They could do it through budget reconciliation, which will be one of the first orders of business when they take session, which would gradually sunset the Affordable Care Act and then preserve some of the subsidies and the Medicaid expansion until whatever the replacement is ready to come online, okay? The other is that they could do a selective repeal with a gradual replace. But look, if it's a political imperative for the Republicans to not disenfranchise 20 million people from the coverage that they now have, then a gradual process is what's going to have to be laid out here. If they try to do this quickly, it's going to result in an enormous dislocation in coverage in the health system that is first going to impact the biggest employers in the state of Texas, and that's your hospitals. Because remember, the biggest benefactors of Obamacare after the people who got covered were hospitals, especially in states with very narrow Medicaid eligibility like Texas, and then didn't take the expansion. What Obamacare did was basically transfer bad debt for these hospitals into pretty crappy catastrophic coverage, but that coverage was better than bad debt for large hospitals, okay? Now, the second you take that coverage away, not only do you have, of that 20 million, you know, about 12 million of them got their coverage through the exchanges. So now you're gonna have 12 million people waving torches and protesting on Capitol steps all over the place, but you're gonna have this huge dislocation in healthcare financing to hospitals in particular, and they tend to be the biggest employers in especially these rural and suburban communities where these votes occurred. So I think this will have to be something that's done gradually if they're looking to avoid a lot of dislocation. Now, having said that, repeal and replace, I think, is really just a marketing slogan at this point, because the things that people like about Obamacare and health reform are totally dependent on the things that people hate about Obamacare and health reform. Okay, so that what we love is a ban on pre-existing conditions. Okay, that just seems to be fair and equitable. But a pre-existing condition ban doesn't work real well without risk adjustment, right? Because now you're letting in all these historically sick people who were pre-X'd and underwritten out of insurance for all this time. You need risk adjustment to offset the risk that we're now enrolling. The lifetime coverage cap, or the couch dwellers provision, as we like to call it, the one that lets your 26-year-old kids stay on your insurance. Well, that doesn't really work effectively, or could damage the way we finance healthcare in this country without an individual mandate. Okay, so this thing can't be unraveled simply. Repeal and replace is just a heinous oversimplification of how this unraveling would actually have to occur, and the fact that most Republicans actually like some of this stuff. So all the stuff that I think stays is what you see on the left. The Medicaid expansion, look, you had a number of Republican governors, including our vice president in waiting, took the expansion. And it's still a damn good deal. I mean, you get 100% match for the first 5 years of the program with broad flexibility to do whatever the hell you want with it. I mean, that's a pretty good deal for these guys. The state innovation grants, that's $25 billion in pork barrel spending that these guys can dish out to their favorite states to try some new things. And then even though the Republicans say they hate the Innovation Center, it's $10 billion in funding that is doing some pretty amazing things, like these almost 500 ACOs, including dozens of them here in Texas that are operating. So you can't dismantle the Innovation Center without leaving all those ACOs in Texas a smoking ruin. Okay, so this isn't as simple as repeal and replace at all. That's a marketing slogan that is going to have to get parsed and walked back as these guys get into the real nitty-gritty of what goes into dismantling this stuff. Now, what's toast and likely to get burned to the ground, the individual mandate. Everybody hates that thing, even though if you really want to make this work, you need a really stiff individual mandate. You know where this works really well? Switzerland, Germany. But their individual mandate is a whole year's income is the penalty. You know, you're going to pay a $50,000 fine in Switzerland if you don't buy health insurance. It's kind of like we are with auto insurance here, right? Where you know you got to have it or you get a huge penalty. Well, here, you know, the individual mandate penalty is $600. So nobody falls in. They're perfectly happy to pay the penalty rather than buy the coverage. So it just hasn't worked anyway. Subsidies are probably gone to be replaced with maybe a tax credit, which won't work as well for poor people, most of whom don't even file taxes because they don't make enough income to be subject to tax. But now in order to get the credit, they would have to file and then get, follow through with all of this stuff. It really is a barrier to access to coverage itself to think about tax credits as being an acceptable substitute for subsidy. The exchanges will get nuked, but not until 2018 or probably 19, because this open enrollment period is already underway. And you could unravel it in 2018, but it'll be disruptive. All of the taxes will be toast, like the Cadillac tax, the device tax. They'll lift all the limits on health savings accounts. They'll get rid of all the essential health benefits rules, both on and off exchange. Okay, and IPAB will be cooked, but the thing never even got the chance of a meeting. So that's what I actually think repeal will end up looking like. And so you're going to have this dynamic of stuff happening above the waterline that you'll read in the headlines of the Dallas Morning News and the Houston Chronicle and the New York Times. And then you're going to have a whole lot of stuff that's going to happen below the waterline and regulations and sub-regulatory guidance as the Republicans begin their real deregulation agenda, which is a big part of what these guys are coming to office to do. So you really aren't going to be able to just pay attention to the headlines on Fox and in your major newspapers. You really got to pay attention to what's going to happen in regulation. And I mean, just in his first day in office, Trump could repeal all of Obama's executive orders with one stroke of a pen. And a lot of Obamacare's operations were tied up in some of those executive orders, and those could be done without the Congress at all and just with one stroke of the pen. Now, here's who he's thinking about to run the Department of Health and Human Services. Sorry, do you like my art? I just couldn't resist on a couple of these. So here is the news this morning. Rick Scott, or Bat Boy, said he didn't want to do it, and little wonder being he's actually still in office and now trying to figure out what to do in Florida. So he's already said no. Carson said no this morning. That was the new news. And said he's just going to be an advisor, and maybe we'll now start working with the Smithsonian Institution on those pyramid grain elevators, and maybe we'll have a nice display there. Mike Huckabee is supposed to be considering either education. So great, now we're going to have a creationist running the education department. But he's not sure that he wants to go to education because basically they're just going to dismantle the department, as Trump has said he wanted to do. So the front runner right now is Bobby Jindal, which, if you know anything about Louisiana, probably just made your stomach flip, because he actually did more economic damage to Louisiana than Katrina did. But having said that, Bobby actually knows what the hell he's doing when it comes to healthcare. I mean, he was the youngest guy to run the Department of Health and Hospitals in Louisiana. He was a very influential member of Bush's advisory group on healthcare and was very closely involved with Tommy Thompson and the whole crowd there. So, you know, this may be a nice redemption story for Jindal if he ends up taking the job. And, you know, I certainly wish him the best of luck and hope he does better than he did as governor of Louisiana. But that's what we're looking at right now for HHS. And I think as of this morning, most of the insider outlets were saying that Bobby was the front runner for it and would be pretty easily confirmed. So it's against that backdrop that we kind of look at where the market in government programs leaves us today. And I'm going to try to speed up here a little bit because there's a lot I want to really discuss with you guys. As we mentioned, the exchanges will be toast. As of now, that's about 12 or 13 million people whose fortunes are up in the air, and we'll wait to see what replace means. Medicaid may be safe, remains to be seen. Effectuating block grants of this program is easier said than done, and I hope that governors and their state Medicaid directors will really have their eyes wide open about what a block grant really means in terms of it being a fixed amount of money and it being an appropriation and not an entitlement. Medicare Advantage, I think, is still okay, and we're projecting will continue to grow at about 4.5% to 5% annually for the foreseeable future. And if Ryan does his Medicare reform plan, like he's now talking about again, assuming Ryan survives the purity purge that's about to happen in the House, I mean, I think they could still do to Ryan what they did to Boehner. And you could see one of the Freedom Caucus guys like Kevin McCarthy really throw his hat in as Ryan not being, you know, far right enough for these guys, but we'll see. But if Ryan's plan gets enacted, that's like pouring gas on that fire. And I think you could easily see us on a pace to almost 30 million beneficiaries in Medicare Advantage by the end of 2023 at the pace that we're on. And then dual eligibles. Again, this is going to be driven by states who are still in one of the worst fiscal crises they've ever seen because state tax revenues are way down, especially in states like Texas. And so the imperative to capitate duals and beneficiaries receiving long-term care services and move them out of these institutions and back into home and community-based settings, which are a fraction of the cost, is still the budget imperative for a lot of these states, including Texas. And as you see, most publicly traded companies have seen their stocks rise more than 1,000% since the Affordable Care Act was enacted. So government programs, guys, keep the lights on in this industry now and are part of the firmament of our financing. And I don't see there being, you know, much retreat from especially the big members of AHIP, you know, really backing down on this at all. This is the status of state Medicaid expansion as it stands today. Worth noting that there are 5 more red states like Utah and Idaho that were contemplating Medicaid expansion at the time of the election and are probably still hopeful that they'll be able to do something like that and not a block grant. But really the remaining holdout red states, Maine will probably be another one that would go in for expansion if given the opportunity. But the remainder of a lot of these states, the problem is not necessarily the governor, it's the state legislature. Like Florida, Rick Scott has actually said, after he watched 3 of his former HCA hospitals fold in Texas because of bad debt. And remember, this guy was the CEO of HCA. 3 HCA hospitals in Texas have folded, in Florida have folded because of bad debt since the law was enacted. He wanted to do the expansion, but the legislature said, hell no. So that may continue. And one little fact you may not be aware of as an election result, We are literally just one state legislature away from Republicans being able to run constitutional amendments through unfettered. So if one more state legislature goes Republican, now the Republicans have 3/4 of state legislatures, which is what's required to enact an amendment to the Constitution. I mean, think about that for a second. That's beyond, I think, any constitutional scholar's ability to comprehend the potential impact of that. Like, they wanted to repeal suffrage. They could repeal suffrage, you know, if they wanted to. So, Medicaid, as you know, a fraction of the population is accountable for the lion's share of the spend. And most of those dollars occur in long-term care settings. So, again, this remains enemy number one of state budgets, and has to be capitated and pushed into the private sector where that risk can be better managed. So this is where you see the lion's share of enrollment is already in health plans. So nationally, about 75% of Medicaid beneficiaries are already in health plans. We're right about 50% in the state of Texas, and I expect that that number is going to grow pretty dramatically over this next couple of years. And, you know, the number of those folks in health plans is really being driven by this. I mean, the fastest growing segment of the U.S. population right now is 85 and older. I mean, just think about that for a second. And we've got baby boomers entering the Medicare program at a rate of 11,000 per day now. And half of them are choosing Medicare Advantage in their first 2 years of enrollment. So this is a much more plan-friendly audience than the World War II generation ever was. And now remember, dual eligibles, Medicare is the primary payer. So for you as health plans and providers, recognizing that the dual eligible special needs plan is the contracting vehicle of the future, and in particular, a model called the FIDE SNP, or the Fully Integrated Dual Eligible SNP. It's a nice mouthful of letters for you, but that was part of the Affordable Care Act that is likely to survive repeal and replace. And that's a product that allows you to, unprecedented flexibility to use Medicare dollars for stuff we've never used before, like Meals on Wheels. You can do that with Medicare dollars in a FIDE SNP. So if that's not yet in your product portfolio, it's certainly something you want to consider. These are the states, including Texas, that went in for the financial alignment demonstration for the duals. The problem is it's been a goat rodeo in this state and elsewhere, largely because upwards of 70% of the beneficiaries are opting out before they ever get a chance to enroll in the program, because they're being scared away by doctors who are afraid of disruption of the relationship, and they're getting scared away by advocates for the disabled. And we as plans are not even getting an opportunity to get out there and talk about the benefit of a managed long-term care benefit for these folks. And I think that's going to change. I think a lot of the states, Texas possibly included, and this depends on the outcome of block grants in this whole debate, but assuming that doesn't happen and that opt-outs continue to plague the financial alignment demo, it's worth noting that almost all states have a home and community-based services waiver that allows for nursing home diversion programs done at a county-by-county basis, where these could be rolled out and managed a lot more effectively. So I think Texas could be among, in a year or two, the states that would pursue doing dual enrollment in health plans through these 1915C home and community-based services waivers as an alternative to these bigger programs that haven't been real successful. And all of these states are already starting to move some of this enrollment through those types of waivers instead. Texas is already down the road on its LTSS program, the Long-Term Services and Supports program, and trying to begin to move greater numbers of beneficiaries into these capitated arrangements where we move these folks out of institutions or prevent them from becoming residents in these places to begin with, and instead are enrolling them in a big wraparound home health benefit with, frankly, a lot of adult daycare. It's basically trying to do a PACE model writ large in how to do it. Now, as that begins to move, you got to really look at this and say, well, is this something that we can be successful in doing? And the truth is, guys, the special needs plan is the most profitable product in all of health insurance when it's done right. Now, my company, we're the plumbers under the sink of the health insurance industry when it comes to government programs. We've done 10 turnarounds of distressed health plans in the last 9 years. 9 of those were precipitated by the duals. And when I say distressed, I mean they lost $100 million minimum in 1 year. That's what makes you distressed under most insurance rules. These beneficiaries will run your plan into a freaking ditch faster than anything will if you try to approach this as on-the-job training. You got to be ready to go on day one when you start enrolling duals or long-term care beneficiaries, or they will absolutely crush your plan, and then you'll end up calling me to pull this thing out of the ditch for you. And you never, ever want to be in that situation. So if you're going to pursue the duals, make it one of, maybe your only or one of 2 maybe big strategic priorities for that year, and make sure all hands are on deck as you begin the planning and execution of how you're going to take care of it, because just the list of services that you have to be able to offer to these populations to ensure you're moving the welcome mat from the hospital and the nursing home to the home and community-based settings instead requires a whole lot of wraparound services that, frankly, many of you in this room are not familiar with contracting for. Okay? So you're talking about food security benefits. How many of you have a contractual relationship with Meals on Wheels or some of the other vendors that are out there to do food security? That's going to be a huge part of this, because what's the number one reason why beneficiaries end up back in the hospital within 30 days? There's 2 reasons. One is food security or insecurity, and the other one is non-compliance with their drug regimens post-discharge. And those 2 things are linked. If they don't have food security, they can't afford both food and medicine. So guess what suffers? And then where do they end up? Right back in the hospital. So if you want to deinstitutionalize, as the goal of these programs is, you got to make sure that basic needs, food, housing, transportation, are met first. Okay? And then you see all of the other challenges that come with this. Now, in Medicare Advantage, we're now pushing up on 19 million beneficiaries in this program. It's a third of the enrollment. And you see what's happened to the penetration since the launch of the drug benefit in 2006. Texas, especially South Texas, has been in the vanguard of that penetration. And when you look at where that enrollment is, it is largely in the big nationals. I want you to notice that down at the bottom, the non-anthem blues missed this train big time. And now they're scrambling to catch up. It's become a real investment imperative for a lot of the blues, like HCSC, which is the sponsor of the Blues of Texas here. But you see how this has become the land of giants for these guys, and that means that you really have to effectively compete better and execute better at the member level than these big nationals do. So STARS is still driving this market. And near as I can tell, unless the Republican deregulation initiative decides to throw this whole thing into the crapper, and I don't think they will, because we've come to be dependent on the STARS bonuses. This is what drives the market now in government programs. And it's coming in Medicaid through QRS. That was part of MACRA, which was a bipartisan piece of legislation, so I don't think that goes anywhere. And so you're going to see this same dynamic in Medicaid as well. And then eventually the commercial market's going to adopt this stuff, guys, because it's already in broad use, and this is what, you know, the plans are already using. So as you know, if you're below 4 stars, you get nothing under this system. If you're under 4 stars, you're circling the toilet bowl. And increasingly, states are using star ratings in Medicare Advantage to determine who gets contracts in Medicaid. There's about a dozen states doing this already. And Texas is certainly looking to integrate more of star ratings and compliance in Medicare Advantage into how they think about who would be good business partners in Medicaid as well. And you know, it's huge money that's at stake here. You've got somewhere between $15 and $50 per member per month per half a star. Now what's happened, and this should be an alarm bell to all of us, is that we're starting to peter out. We're seeing stagnation and the consistent quality improvement that we saw in the early years of star ratings. So this year we flattened out in terms of the average star rating, and then I'll run you through these measures, but I want to show you guys especially where the stagnation's occurring. So these are the measures for 2017. And I want you to look, and in particular, the highlighted measures are the ones that are triple weighted. And you'll notice the common thread among all of these is that these are real outcomes measures now that you're seeing here. So blood sugar controlled, that's an outcome. There's a clinical definition of blood sugar under control, and that's a triple weighted measure. Then you see the CAPS measures are ranked at a 1.5 weight. The health plan quality improvement measure, which is company-wide, is weighted at 5 now. So that one alone can kill your company if you're not. Matter more toward the star rating now than the other clinical measures that we just looked at. So when you think about that, that means that your PBM is the most important vendor you ever picked and ever will pick for the rest of your career. Okay, these guys now determine whether or not all the Part D measures are successful, and this counts more toward your rating than anything else in how this stuff gets calculated. So when you look at where we're succeeding, you see a lot of these measures where the PBM is absolutely central to being successful. Fall risks is the worst measure in all the star ratings. What's the #1 contributor to falls? Drug overdose. And in particular, use of sleep medications. So just think about this measure and what happened a couple of years ago. What went generic a couple of years ago in sleep medications? Ambien and Lunesta went generic a couple of years ago. It's just one example, okay? What happens when a drug goes generic? More or fewer people use it? A lot more. In fact, in those medicines in Texas, 4 times more people started using Ambien and Lunesta. And after this freaking election, I'm sure there's even more just to help with the anxiety and the sleepless nights. So now think about that. Now the denominator of that measure just increased 4x. Because these are medications that make these folks woozy and imbalanced, and then they get out of bed and they fall down and boom. Okay, so just as one example there. But when you look at where the stagnation's really occurring, of the 47 measures, 13 measures have shown no improvement in 3 consecutive years. We got a lot of work to do, guys. And when you look at those measures, you see how hard these are to really keep moving upwards, especially when these cut points are getting more aggressive. I mean, the bar is rising here. And so we have to improve on these measures in particular to stay ahead of this graded curve that we're all scored on, okay? And when you look at What also contributes to that rating, more than half of your rating is determined by your members' experience. And it's measured by the CAPS survey in particular. Now, dual eligibles are a huge drag on your star rating because duals are disproportionately older, chronically ill, way more depressed. And what happens when the federal surveyors call up a dual eligible with 4 chronic conditions, taking 14 different medications, and she hasn't been able to leave the house in 3 years, she's so sick. What does she tell the surveyor? When they say, do you feel your health has improved since you enrolled in XYZ health plan? She said, no, I don't feel any better. I mean, I'm barely feeling like I did a couple of years ago. Most days I feel worse. Boom. And then the bottom falls out of your member experience measures. So we have to really think about this, and when you parse the CAPS survey, I really wanted to show you guys the numbers from this year. Look at this. The red is what gets you to a 2-star score on that measure. Green is what gets you to a 5-star. The difference, you see on the scale on the left, it's less than 10% performance determines the difference between 2 stars and 5 stars. So guys, this is more than half of your rating. And literally, on most of those measures, you see on the bottom axis there, it literally could come down to a couple of dozen of your members completely screwing up your CAP score. Literally, a couple of dozen people that could absolutely blow your rating year over year. This is in part what happened to Humana. They got hit, not just with, they got hit on an audit, and then CMS knocked their score down on that, but they're fighting that, and they may be successful. But this is in part what drove 34 plans to lose their 4th star. And when you lose that 4th star, you just lost all the money that you already had booked. So this is way worse for a 4-star plan to lose the rating than it is for a 3-star plan to get it, because the 4-star plan already booked the revenue. Okay? To give you a little glimpse into where NCQA and some of the other advisory groups that develop these measures are going, I want to show you guys the focus is much more on chronic illness, it's much more on mental and behavioral health services integration, and it's much more on developing measures for the duals and other vulnerable populations. So the bar is only getting higher. And, you know, it's like I tell my daughters, you know, the difference between who you are today and who you want to be next year is what you do. And in what we do, that's reflected in budgets that most of your organizations are building right now. And if you're not investing heavily in your ability to deliver on a pay-for-performance initiative around these kinds of conditions, you are going to get left behind and won't be sitting in this ballroom 5 years from now. Okay? So when you look at where the stars are scored, I want to show you the spillover effect here in Texas. Because Texas and much of the Deep South were lagging behind where the rest of the country was in stars. And one of the reasons is, look at the graph over on the left. In terms of the overall health system performance, it's way down in Texas. In fact, we have to work pretty hard in Texas to have low quality measures like this. And most of that is coming from our inpatient provider partners, okay, as reflected in hospital star ratings and some of the other JCO accreditation measures that they've got. And then you overlay that with the preponderance of of 3-star plans in Texas, especially in the eastern part of the state, and you see the correlation. The plans that have been consistently high star rated, the only company that's been 5 stars since the inception of this program has been Kaiser. Why? What's different about Kaiser than about the rest of us? Their staff model. Or to be all Leninist or Stalinist about it, or Putin-esque, as Trump likes to be, they control the means of production. So the companies that blur the lines between insurer and provider and are the most collaborative are going to be the ones who are most successful in a star ratings environment here. The other asset that you have in your communities that is totally underutilized is the retail pharmacy. You're embarking on some tough work here. I mean, you already brought in most of your reasonably well-off beneficiaries into your system, and that's how you've gotten your rating to date. The folks that are left and that are still outside the system are underserved and vulnerable. In rural and in inner city communities where you have really medically underserved areas and real problems of access for these folks. Well, in every one of these communities, there's a CVS, or there's a Walgreens, or a Rite Aid. And it's the most valuable real estate for all of you going and serving these populations, because guess what else there isn't in these underserved communities? They're all food deserts as well. So why does a retail pharmacy have, on average, 4 dozen encounters with a senior citizen on average every year? Because they're also buying their groceries there, okay? And so when you think of the retail pharmacy as the hive or the hub of what could be healthcare access for all of you guys, this is where medication counseling should be going on. This is where specialty consults and telehealth visits could be happening. The retail pharmacy really needs to be one of your closest allies in delivering on this. And don't lose sight of the fact that this is how CMS is judging, and increasingly state Medicaid departments are judging who's going to be a good business partner, is on the basis of performance in stars. So we expect that that activity will be at an all-time high again next year, even with this incoming administration. While most of us weren't looking, penalties were doubled for most infractions that health plans find themselves guilty of. And the biggest priorities that they will have are going to be around delegation and PBM oversight, consumer protections. Of the 34 plans that lost their 4th star, 18 of them lost it for one reason: because they screwed up appeals and grievances on drug benefits. That's just unforgivable, guys. I mean, one, those regs have been out for 18 freaking years. You know, we should be able to tell the difference between a complaint and a coverage dispute at this point. But the other is that most of us let our PBMs handle appeals and grievances on the drug benefit, and they obviously don't know what the hell they're doing with it. So pay attention there in particular. And then network adequacy is probably going to be a close third in terms of priorities for CMS, and you know, those especially those long-term services that we mentioned earlier. So they almost tripled the number of civil money penalties last year, and we should expect that to continue next year, and that CMS is going to audit upwards of 98% of plans this coming year unless the incoming administration tells them not to. So to bring this all home, these were the same skills that we talked about when we were together last year, and they still remain what will determine who lives and who dies in this next couple of years. This is the new basics that we have to get back to. And these are skill sets that most health plans are still behind in if you came up in the commercial market. Because these are just not the kind of things that you need to be successful taking care of group commercial members. But they are do or die in Medicare and Medicaid. So as we mentioned last year, membership accounting. I mean, that's a dumping ground for employees that you don't know what the hell else to do with in many health plans. In this one, in this new world we're in, it's do or die. You want your membership accounting and enrollment shop to be the den of the frickin' ninjas, and you want them all to be like unmedicated OCDs with a little hint of Asperger's, and you know, they're just into this, you know, and they're selling their knitting on Etsy over the weekends and stuff, but during the day, they're the most anal retentive people attending to every single last detail. That's what you want in your enrollment shop. A proactive customer service unit. You don't want to sit back and wait for the phone to ring. You want to be making outbound calls to members and making services available in their communities. Seeing a lot more of our clients setting up retail stores in some of these communities that they're now entering into. They've got mobile vans that they're going out and doing screenings and just general information sessions with in the communities. Risk adjustment, still critical. And when you consider mastering stars and mastering risk adjustment depends on the same diagnostic data. That's mission critical and you gotta have it. But that one down at the bottom, I think to my mind, is the most important. Because if you don't have a good working relationship with your providers in an environment where you gotta control the means of production to deliver a result and get paid on that result, you're just not gonna be here for very long. So in conclusion, government programs are going to continue to drive your revenue and earnings, even in a Trump administration that seems decidedly anti-government. Exchanges are dead in 2018 and 2019. Focus your attention on Medicaid, because that's where the action will be. I think Medicare Advantage and the Medicaid expansions are mostly safe, and I hope Texas won't fall for this, this silliness that we call block grants. Star ratings and the forthcoming QRS will drive everything that you know of the market in Medicare and Medicaid. There is no innovation without collaboration. All of your CEOs want to retire being the innovation chief, right? They all want to be the big innovation boss. And you know what? I've got clients that are spending $20 million on big data every year. Big data has not cured a single case of diabetes, to my understanding. You know what does is rather than spending 20 million on that, spend 20 million bucks on social workers, and you'll get a hell of a lot further. That what works is low tech. And getting a nurse's hands on the right patient in the right setting at the right time. Getting that person counseling on those 14 different medications they're taking and how not to poison themselves. Getting them transportation to that doctor's visit so they don't end up $1 million baby on the ER doorstep. Not talking about members-centric or patient-centered anymore. Start talking about person-centered care. Because I think we're on the edge of a new 80-20 rule in health insurance in the Trump era, guys. Which is, the old 80-20 rule was 20% of your members determine 80% of your costs. The new 80-20 rule is going to be that 80% of what you do as health plans has nothing to do with healthcare. It makes it more accessible and easier to get to and more effective. That's what the new 80-20 rule is going to be. And it's going to be decidedly low tech and high touch that wins. And remember what Edison said, vision without execution is hallucination. So really make sure that this stuff exists at the workflow level if you want this stuff to stick and endure through the next 4 years, and God knows what happens after that. Okay? So, questions? I know we ran over a little bit. My apologies. So much to talk about.
We're just going to do
Take one question, and then I can hang out for a little bit and answer. Hi, Mark.
Hey, thanks, John. You mentioned subsidies will probably go away. I'm imagining for this changes. What's the impact to low-income subsidies for duals, MA plans?
I don't think you're going to see any impact to low-income subsidies or the LIST program in Medicare Part D. I think what they're talking about is just eliminating just Obamacare subsidies and just erasing anything that had his name on it. But that's sort of where all the duplicity on the 3 R's has existed. You know, Marco Rubio and his cabal gutted the risk corridors and stuff in Obamacare, saying it was a bailout, and that's why you're seeing so many price increases this year. But you know, they don't feel that way about risk corridors and risk adjustment in Part D or in Medicare Advantage, because that was a Republican initiative. So I don't think you're going to see any of this stuff over there in Medicare Part D or in MA at all. And I think if the money was down and I had to bet, I'd say subsidies end up getting replaced with some sort of tax credit. And you know, I think the real beneficiary of that is going to be H&R.